Welcome, everyone. Thank you for joining us for our first in a four-part series specifically for and created by internal medicine faculty in Phoenix. Today's session is Teaching on the Fly by Dr. David Wisinger. I'm Dr. Jessica Seaman, Assistant Dean for Faculty Development, Creighton School of Medicine. Just a few housekeeping items before I turn it over to Dr. Wisinger. This session is being recorded and you will have access to the recording and slide presentation for future reference. We invite you to ask live questions or submit them in the chat. We'll get to as many as we can by the end of the session. We do ask that you remain muted with video off unless asking a live question to assist with the recording. Also, this session is eligible for CE credit and we'll share the website and activity code before we conclude. As a reminder, participation in all four sessions of the Internal Medicine series is required by your program leadership this academic year. If you aren't available for the live sessions, you are asked to watch the recording, log into CME Tracker, fill out the very short survey, and receive your participation certificate to then email to your program coordinator. If there are questions regarding these faculty requirements, please reach out to your program director or coordinator. Now, Dr. Wisinger, if you're ready.
Yeah, I am ready. And I don't know if Jaya has made it onto this or not. I was going to have Shannon Skinner just pipe in as the site program director to remind people as to the rationale behind this series that we're running. Shannon, if you're there, you can.
Certainly. Nope, I'm here. So the intent behind this, for most of you who've been here and are aware, the residents are required annually to complete an ACGME survey. And as the program, what we do is we sit down and look at all of that data when we get it back, and we did that in the spring. And there were some areas that were noted to be kind of concern consistently and have been for the last few years and more so this year. And we used that information to kind of come up with these 4 topics that are going to be covered, one today and pretty much one a month for the next 4 months. And they are required from the program. And it's just a way for us to kind of validate to the ACGME and honestly for the residents to know that we take their input seriously and here's what we want to do to try and do a better job on some areas that they have noted that they have some concern from our side. So I'd say that's at least what I have. I'd say go for it, Dr. Wisinger.
Thanks, everybody. And as Jessica said, I'm more than willing to take commentary during the talk, and certainly I'll answer some questions towards the end. So this was titled kind of Teaching on the Fly, but what I really want to make sure we're aware of is that some of the commentary, as Shannon referred to in the ACGME survey, had to do with some consistency that the residents felt they weren't getting with regards to quote unquote teaching. Now, I got to be honest with you, teaching is kind of a relative term as you find out when you query learners. So we're going to go over some of the brief history of some teaching as it pertains to the medical arena and talk about what we used to do, what we think we're doing now, what we should be doing going forward. And although it's kind of tailored a bit towards rounding, as it were, from a hospitalized perspective, we know teaching takes place in clinic and other settings. The concepts are applicable there too. So we're going to talk about the history of rounds, the roles of attendings, kind of the difference between the different generations that are out there performing faculty directed teaching, what we think is happening, what probably really is happening, and certainly what we can do going forward. So for those of you who have been engaged in graduate medical education for a while, and I admit I've been doing this for a while, and some of you literally have just started, as it were. But, back in the day, we used to kind of focus on supporting learners in the pursuit of independent practice. In other words, it was a kind of a see one, do one, teach one modality. And learners often made decisions in the absence of a supervisor. And you don't want to hear the stories, but there are stories. And I know some of you who are older are nodding your head about some of these stories, which get a little fuzzier as you get older, but actually at the time were not very good. Nowadays, we're trying to be more specific in preparing learners for an unsupervised practice, but with the intent to act well with others give them some autonomy, but really are obligated to have a level of supervision commensurate to their degree of success in training. That's what we're going to talk about a little bit further here. Back in the day, people have heard of Osler. You kind of wonder where the term rounding came from. Well, just as an FYI, the hallways back in Johns Hopkins back in the day were kind of circular. So as physicians went around with Dr. Osler, they actually went around, and thus the term rounds came to be termed. The other term where you hear rounds is quote unquote grand rounds, which tend to be take an interesting patient and literally kind of observe the patient and talk about them, often in a theater type setting. So again, older style teaching was often where patients may not have been seen directly by the faculty. The quote details were left to the resident. Certainly, the teaching faculty at times were in realms that they may or may not have been very comfortable with. For example, I can speak to the fact directly that we had specialists often doing inpatient rounds, which sometimes was very good, but sometimes you could tell specialists were very focused into their organ systems and had discomfort dealing with the care of patients beyond that. There was certainly more time to pontificate. There wasn't kind of the time pressure of getting patients out of the hospital, getting multiple things done. The data points were less to deal with, et cetera. A serious consequence of time of back then was the non-motivated resident was allowed to commit disaster. That was an actual fact, and we won't expand upon that because there may be a lawyer in the audience. And there were a few checks and balances, and of course there were some consequences of that. So way back in the day in Osler times, you kind of had somebody pontificating about a patient and you had people standing around. What you notice here is a bunch of white men, kind of a sign of the times, although somebody looks as though they snuck in here. And you know what, not all that long ago, kind of similar, maybe not as dramatic in terms of numbers, maybe a little more diversity barely. People aging themselves with the bow tie, but kind of similar, if you will. So do we really make much progress? So today, things are a little different. You have people who tend to be more generalist in their approach, at least for having learners participate in the care of general patients. Ideally, you want to see the patients, review the data, interact, God forbid, with some ancillary personnel, discuss with consultants, et cetera. So this is kind of an ideal thing, and the reason I highlighted it as such. Many people, unfortunately, are rounding into a room with an EMR at the ready, which unfortunately isn't always at the bedside, and a lot of activity or a lot of outcomes measurements in terms of length of stay and readmission rates and adherence to core compliance, core measures, I should say, are a part of rounding, which wasn't the case years ago. Does this look familiar? All right, so what do you notice in this a lot? Well, A, people are staring at everything except what they should be, which is each other, the instructor, and or God forbid, the patient. And you can imagine there's a lot of play of information taking place that's actually still in a public arena, so you have to be careful there, but nobody's looking at each other. And I got to be honest with you, having done rounds for a long time, I find that many faculty and subsequently the learners do not spend nearly enough time with the patient at the bedside. Yes, I may sound kind of old. Why? Because I'm older and I'm the minority doing this, but I'm going to stress this point more as we talk a little bit further. So oftentimes, and this is important from a survey response perspective, you know, the question is you want learners to get comfortable as to what they see and what they recognize as actual teaching. Teaching is still viewed by many, both faculty, but particularly by learners, as something where there's a specific lecture-based topic that's discussed. And if it isn't done in that kind of, I'm telling you something and you're going to listen for a while, that's teaching, but all the other nuanced interplay between faculty and learner is often not felt to be teaching, when in actuality it really is. And in fact, we know, or at least the faculty should be aware, that the most effective facilitating of adult learning is really more case-based, is more thoughtful, is more reactive, and that the actual lecture-based, the retention is actually not very good. And that's been shown in multiple studies. So if you ask faculty what they're doing, and this was done about 10 years ago in this particular study from JGIM, the faculty from multiple academic medical centers were surveyed, and they stated that they had patient-centered strategies, They saw buy-in from their learners by asking learners for objectives. They defined what they expected. They would not quote unquote round with the low value patients, and they would commit to learners and their time. Now, before you grab, I can tell you if there were residents in on this discussion now, they'd be reaching for the bucket and probably having projectile vomiting, because they would say that that's not routinely what faculty are doing. And faculty in this survey commented that they should be preparing for rounds. Well, I got to be honest with you, having done direct observation of folks, at least on this side of the fence, that isn't always the case, but the value of that I'll talk about here shortly. So this is what older people kind of said they did. So what's actually happening? Well, they did some observation here in this particular study with actually quite a robust denominator, watching people for a couple of months. And really, what often happened, it was really kind of just a assessment and review of the data points, right? Looking at care plans, labs, medications, which is not unimportant. It is important, but it shouldn't be the primary directive necessarily. And they rarely were looking at things that they may be measured on in terms of adherence to those core measures. Interprofessional communication took place rarely. And the big one here to me is that there was rarely action at the bedside. I cannot stress how important that is. And that's true whether you're in clinic, whether you're in the hospital, whatever site you're at. If you're not engaging the patient as part of the teaching, we're missing out totally. That's too small to matter at this point. So today, if you think about it, faculty are obligated to try to really teach multiple trainees at the same time often. And of course, many of them are at different levels. And if you haven't gotten a sense that the number of learners that we are now as faculty being asked to teach is large, it can be cumbersome physically in terms of being able to see and talk and hear folks. The differential in their experience is dramatic. So you're trying to constantly shift your gears as you're talking to them. It's doable, but you have to really actively think about how you're doing that. You're supposed to be giving some feedback, and sometimes the feedback can be given kind of covertly. Sometimes it can be overtly. And of course, professionally should be done in a setting that's not going to compromise the status of the learner. You're also trying to regularly gauge the degree of autonomy to allow somebody, i.e., as people might say on the side, does this person scare me? Does this learner scare me in terms of being taking care of somebody? Well, you're obligated to ensure for patient care that they don't scare you, and they certainly don't scare the patient. And that can be difficult to do with just a few touches. I've noticed over time that our contact, our continuity of contact with the learners is limited. And I got to be honest with you, unless you're really, Kreskin, you're really astute, it's hard to sometimes gauge the learner's capabilities just in a couple of touches. The whole team being together doesn't happen most of the or a lot of the time. And so there's a lot of discontinuity with that. Duty hour restrictions, they are what they are. And in fact, people who are older, faculty will often comment to say, well, these kids get days off and we never had days off and, blah, blah, blah. Well, let me tell you something, their days are packed, right? So they're trying to cram in within their duty hours a lot of stuff. So it's hard to do, and their ability to process quickly can be challenging, although luckily they have young, more malleable brains than we do, at least the older end. So is this something more current today where we're actually seeing patients without really seeing patients or touching patients? It says, I hope you don't mind me bringing a few medical students in to see you, and then everybody's kind of got their view here remotely. So what is the Holy Grail? Perhaps it's how to keep the good of the old era that promoted personal responsibility and medical decision-making, and I'm going to reference that here in a minute, with the good of the current era, which is more supervision, more guidance. Again, how do you balance wanting to give the learner a chance to think, to make decisions, correctly or incorrectly, but at least make decisions, be there to provide oversight, do it in a timely fashion and make sure that it's not dangerously done, versus just having the house officer or the learner be a scribe. And I will confess to this, if I have a service that's packed, very busy, things are going to be a bit more directed potentially during rounds. And if the service is lighter, then you can be a bit more, pontificate and more relaxed, if you will, as you're teaching. And that's just the reality. So the reality is the services vary in their complexity and in their how busy they are. But your job is to constantly be having your hand on the gear, shifting it based on the skill set of the resident, the complexity of the patient, the number of patients, the time constraint. It's hard, in my opinion, to be a good medical teacher, but it can be done if you want it to be done. And the last part here, as I said at the bottom, the art of teaching is the art of assisting discovery. In other words, I think sometimes faculty feel as though they have to be this, this vault of facts. And the answer is no. What you're really trying to teach, I hope, is how to think, how to kind of look at the bigger picture and get house staff to not just react to data points, but to actually figure out how to put the picture together. Why is it we're doing what we're doing? I'll mention that here again in a minute. All right, so I'm the old guy, one of the old guys, and I gotta say, stick to the clock. I have heard, and it didn't surprise me on the ACGME survey, that we have some faculty that don't start rounds early, that go beyond a couple hours, that routinely do this irrespective of what the house staff have to do later. That is unbelievably rude, and it's unbelievably unacceptable. So you really have to tone it down. And if that means that you're going to see some of the patients on your own, that's what you do. But the fact of the matter is you've got to stick to the clock. And that's a chronic issue on both sides of the fence. I know it for a fact. But I can't stress how important it is, not only from a logistics and operational perspective, but quite frankly, to be polite and to be considerate of the residents. They absolutely notice this and they absolutely resent it every time it's violated. And I won't say any more about that. The next one is, I feel very important, is to round with the patient. I've been doing this for over 30 years. I always ask, of course, when we come into rounds, to introduce who we are, why we're here, and are they okay with us discussing their case? I can count on a hand in thousands of encounters, literally, how often a patient said, no, I don't want to have everybody here. I just want to see you. All right, fine. It is unbelievably rare. The patients very much, and again, I'm speaking here from a Valleywise or Maricopa perspective, they want to know what's going on. They want to participate, and they often do. They correct sometimes the residents when they're talking about a history and say, no, that's not what I said, or that's not what happened. They very much want to hear what's going on. When I've talked to them afterwards to say if they have any questions, this is after rounds when residents are not there, they often say, people haven't involved me before. And I really appreciate that because I feel like you're really paying attention to me. You care about how I do. I can't stress how important that is. So, okay. The next on here is know your patients prior to rounds. Do not go to rounds to find out what's going on. A, takes longer to learn, therefore you're violating the 2-hour time rule, my 2-hour time rule. And B, you aren't going to find all that's going on with the residents telling you because they don't know all that's going on typically. Know your patients prior to rounds. Remember, rounds are for you to assess the learners and to ensure safe care takes place. It's not to find out what's going on. Before I see patients, I go through each and every patient through the EMR and know the labs, know the nursing notes, know whatever before I round. So I'm not surprised, and I'm almost never surprised. So, and I will tell you something else as a caveat. When the residents realize you know what's going on, they can't pull one past you, they get a little better at actually telling you what's going on. Decide ahead what you're going to teach about. If you have a service that's got 15, 16 people, there's 4 or 5 salient points that you want to kind of bring home. Keep them in mind, put them on your list. I have to write them down for me. I'm sorry, I'm old. And then when I get to those patients, I want to stress certain points, whether it's assessing literacy and compliance, whether it's a physical exam finding, whether it's a disease state, whatever. But do it ahead of time. Remember, to teach properly means you have to prepare. Prepare doesn't mean just showing up. A thing I like to do now with the EMR, although I used to do it with hard copies, believe it or not, is I like to show the patients their x-rays and sometimes their EKGs. And they're like, wow, what's that? Is that my lungs? They are enamored with this routinely again, shows them that you're engaging them, that they're important, and that you're actually thinking about how they're doing. Unbelievably powerful. And God forbid the house staff actually learn how to read an x-ray versus just reading the x-ray report. Another strategy I use is I start with pretty basic questions just to kind of get them in the game, keep it easy. They sometimes miss. Yeah, sometimes they miss. So then you make it even simpler, whatever. But, don't, that word pimp just basically raises the hair on many people. Like, there's a way to kind of ask questions in a way such that it isn't like, well, don't you know this? A lot has to do with style. Oftentimes, I don't really rely just on facts per se, but we really want to know kind of what they're thinking. For example, why make this antibiotic choice? How will you ensure this patient understands and has a better chance to comply? That one gets them almost every time because they don't think beyond just the medicine per se. They have no idea whether these patients can read. They have no idea about their transportation. They have no idea if they really know about the illness that they have. There's many psychosocial factors that go into their care. Sometimes they don't ask because they never think of it. And sometimes they don't ask because they don't know how to fix it. You're not going to always fix everything, but there are ways to enhance compliance and understanding. And that's part of what we teach. And finally, just like today, even a lot of what, the residents on their survey, they had some specific examples they pointed out to that were aberrant from what was expected, such as so-and-so rounded too long, or so-and-so, wasn't aware of the patient, or things like this. But a lot of what they commented on was just the vibe and the environment to which they were being taught. It goes along the lines of, as at least Maya Angelou is credited with this, I've learned that people will forget what you said, people will forget what you did, but they'll never forget how you made them feel. There are some faculty that the residents just don't like. Okay, now we can't make everybody likable per se, but we have to work on those who need to kind of just settle down and not have a confrontational encounters with the house officers. And they may look back and say, well, when I was a resident, or I was a fellow, or I was in clinic, or whatever, somebody just made me feel crappy. And I think that's just kind of what attendings do to residents. No, it's not. And us as leaders, and certainly as program directors and APTVs, our job is to, if we have failing faculty, we need to address them directly. And remember, as a faculty member, it really isn't about you, it's about the learner. That's why we're here. We're here mainly to make sure patients get taken care of well, but also that we're effectively engaging the learners, because that's the product that's going out into the community. Okay, so that's what I have. I'm going to stop the share. I always like to keep things tight. And I am now open to whoever has any questions or comments. Or none. I'm hoping whatever it is I spoke of, you could relate to a certain extent. I would say the biggest one, I will just say it again, is I think teaching without engaging the patient as part of the teaching moments is a mistake. I'm not saying you have to have all time spent at the bedside, and certainly there's a time to not be at the bedside during certain elements of discussion, or be in the room in the clinic with the patient. But engaging the patient in the learning process, I think, is really important. Patients universally like that. They want to know that their care matters to you and to the learner, and it can be a real upbeat experience, in my opinion. I just think it's underappreciated by many faculty who tend to want to just sit in a room or sit by the EMR or pontificate, and then rarely engage the patient. Hey, how you doing? Everything's good. Yeah, that's great. Okay, bye. Just my thing. So,
Dr. Wisinger, Surabhi.
so Ravi, how are you?
I'm good. I'm just shocked how interesting you made this talk. So thank you.
Well, thank you. Hopefully we can, I've been doing this a long time, but I know I can definitely be better at it, and I'm still learning. If I had moments where I felt I was inappropriate with a learner, the answer is yes. And there are times when I either go back to them directly to discuss it, or I hate to, I'll admit this, sometimes during rounds, I'll make up with them by really kind of, picking on them to make them look great. And then suddenly we kind of get past it. So yes, I have my moments. I'm human. I've had bad days for sure. But anyway.
Yeah, sometimes you get overwhelmed, or sometimes I remember like a resident didn't mention to me that the patient's platelet count was 2, like till like later in the day.
Yeah.
Or didn't mention it at all. Like she hadn't bothered to look at it. So that really upset me, because that's the only thing we were following on that patient, Patient was admitted with ITP, and that's all I had told her to follow up on. So it makes me feel like they don't care, and that upsets me more than, any knowledge deficit.
Sure. And I'm not sure it's a not care thing, although I see where you're coming from. And I think the tough part for sure is to step back and make sure the resident, do you understand what it is we were primarily following as a specialist, let's say, on this particular patient? The answer either is no, they didn't know that, which is an issue, or B, they knew that but felt uncomfortable to say it because they weren't sure how to explain it. That's what I mean about, preparing before by knowing a lot of the data points before you meet the learner, because a lot of times it's that learners won't tell you things not because they don't know the data, but they're not sure what to do with the data, so they're afraid to bring it up. And you need to tell them, once they realize that you do know, you need to tell them it's okay. We're here to learn how to learn, right? Learn how to think. If you were going to be excellent at everything, then why are you going through training? They have to know that this is a process, and we as faculty, as much as we want them to kind of get it, it's a process, and they're all variable, by the way, as you well know. Just because our learning assessments are done more on a calendar based more than a accomplishment based, which is a challenge, right? So some people are better at 8 months than others, and they may take 12 or 14 or whatever. So your job is to try to read that. It's hard. It is hard. This is not easy, and it's not meant to be easy, but that's why we're here. So anyway, well, there you go, Sarabi.
My only other feedback is that, not for you, but in general for the talk, and it'll just make me sound old and grumpy, but they don't, like, they're so focused on their devices, like they don't want to look at the patient. I've had people come and present me a case in clinic and they have not seen the patient at all. And I'm like, have you talk to the patient? They're like, no, I looked at Epic and this is what's going on. And I'm like, I want you to talk to the patient before you talk to me, because I don't want to go there without patient might be half dead, like from oncology, we need to know the performance status. A lot of things you can't make out from the chart.
Right. And I think, again, you just engaged in teaching, which is, the learner needs to know what is reasonable to expect when encountering the patient beyond just the number, right? The platelet count, for example.
Right.
What is their functional status? What is their awareness? How are they feeling? Are they safe at home? Those kinds of things you can get from the EMR, as you totally
You cannot. But the difference is, again, it just makes me sound old and bitchy, but if I ever presented a case to an attending without having seen the patient, they would rip you a new one. So that's not something you did, right? Now it's acceptable to do that. And we had electronic medical records too.
I would say this, that as you were kind of alluding to, never assume that the learner knows what they need to know. In other words, now, having said that, all right, I'll say this is what we're doing. I often say at the bedside, if they're going to be presenting a new case, I say, this is what we're going to do. This is a such and such year old lady with a history of something who presents with a chief complaint of something. Okay, go at it. And I give you a maximum of 2 minutes. And if we're doing follow-up visits and so forth, and I see them looking at their papers, I gently tap their arm and I put the paper down. I say, look, just tell me what you know about this patient. You don't need to read me normal, right? Well, their blood pressure was what? No, normal is normal. Okay, let's move on to what matters. So it's okay, I think, to be very, to guide them, right? Don't stand there and listen to somebody babble for 3 minutes who's just drowning miserably in front of you, having no clue what's going on. Just throw them the life preserver, say, okay, we're going to stop right here. Let's focus on this. Let them kind of climb back into the boat, so to speak. So I'm not a sailor, so I apologize for the crap metaphors. But my point is that it's, in my opinion, okay to be directive for them. Don't let them just flail and so forth, because then you can see the whole team around them kind of getting uncomfortable, like, oh man, I'm sure glad I'm not him. No, that's not why we're here.
I mean, that doesn't serve any purpose, just makes them feel bad. So that's completely pointless.
Exactly.
But yeah, they need to like look up from their devices though.
But we should be able to say, put the phone down, look over here, and if you engage in eye contact with them, they
But
typically
Dr.
won't.
Wisinger, wouldn't that be like a 360 saying like she was really mean to me and she told me to put my phone down and told me to make eye contact? It sounds rude even if you say it politely.
I think that you do what you think is reasonable to do. If they can't understand the value of that, then that's too bad. And I can imagine, maybe I could ask the people who are actually in the business of doing this as APDs or site PDs, whatever, or PDs, to say, look, are you going to take a negative comment when somebody says the attending wanted me to engage with them as we talked about a patient? I don't think so. So I would say, do what you feel needs to be done. Do it politely and professionally, and you'd be surprised. Most of them come around quite nicely, in my opinion.
I just feed them if they're too upset. That's my solution to everything.
Anyway,
Well, if you're saying it right up front, like Dr. Wisinger talked about, I feel like it makes a big difference. I work so much with residents, so much with learners, and they like knowing what their expectations.
exactly.
So, and I also teach residents to, when they are teaching, when I'm doing the residents as teachers session, then I'm telling them, talk out loud, say what you want somebody to do, a learner to do, but you have to say it out loud. So that is okay. But you're saying it up front and you're saying, these are what my expectations are. David, we do have somebody with their hand up, so I'm going to let him unmute himself and ask a question.
Sure, of course.
David, can you hear me? It's Bill.
You right. How are you?
Yeah, good. Thanks
Good.
for the excellent talk. I think what, in the bigger perspective, what you shared with us today is more of the ideal scenario that we would like for our learners. It's doable, but not always practical. I feel like, I think a big part that we may have to at least mention would be, service interruptions where, residents may be pulled to admit patients or whatnot. So I think that needs to be factored as well, and kind of, work with around that as well. To the point that Dr. Amar mentioned, I think she took up when I was going to ask from me in a way. I think there's a generational shift in how we learn. And when you mentioned generational, I was expecting you may mention about the, Gen X, millennials, Gen Zs and whatnot. But I believe a while back I have come across some things where I think as there's a generational shift of how we learn and how we grasp things. And this generation may lean towards more, screen time and other things with advanced technology. And there we may be needed either to adapt ourselves to some extent, or we may have to ask the younger generation to kind of redirect them in how we want the learning process to proceed. If anyone has any idea about that, it would be nice to mention. I don't know if you know anything about that as well.
I appreciate that comment, and I would say for sure the availability of data points through the EMR and through the internet in general can be great, right? But remember, there still doesn't substitute for thinking and trying to organize your thoughts and understand where you want to go with managing this patient. Yes, there are a lot of things to know, but again, to reiterate, your point is generations do change. I get that, and that's a good thing. But we're still stewards of how it is they might best learn. And you can do that cross generations. You know what I'm saying? Yes, we look back sometimes at the way we were when we didn't have quite as much supervision and there was more autonomy and this and that. There were some pluses to that because it really put you in a position to have to think on your own. But it also was really bad because sometimes you had to think on your own and you did some bad things. So take the good with the bad. And again, set the tone. I want to go back really quick to that point though that Jessica was making too. it is okay, and I think preferred, to kind of set up what it is that you're looking to do with each patient encounter. And it may be quick, it may be long, but I think just to go in there and assume everybody kind of gets it is just bad. It's bad for the patient because it looks unorganized. I think it's bad for the care in general. And remember, you're dealing with learners often, whether it's cardiology services that you run or otherwise, that are from multiple different stages of their education. So you have to kind of, I think, lay down what it is you're expecting to have happen. And they're like, okay, then that's what we're going to do. And if he doesn't really want me gazing on my phone during round, I'm not going to do that because he's not expecting me to know every data point off the top of my head. And I'm not. That's what the EMR can be when you need to reference it. But to just bury yourself in the data is having you escape from what you really should be doing, which is thinking about why you're doing what you're doing. That to me is our task. But others may have different thoughts, and I appreciate yours, BY, of course.
Dr. Wisinger, can you read the chat, or would you like me to read it?
I saw Doug Nelson's comment here, if that's what you're referring to. Yes, the residents do have a lot going on. And remember, all right, so I'm a guy in my 60s, trained a long time ago, definitely didn't have as many data points to keep track of as they have to now. And yet what we have going for us as we age, presumably, is the ability to kind of synthesize and sift through what's not important. They don't typically, right? So they're trying to deal with an unbelievable amount of stuff that they don't know what's important, not important. Again, that's why teaching's hard. If you want to do it well, teaching can be hard, but hopefully you want to do this, which is why you're here. So let's show them that they want to do it. I will say a final death blow on a survey response is when there's comments from residents that comment that faculty look like they don't want to be here, or they don't want to be doing this. That should be the biggest, alarm going off of anything. So, and it either could be because the faculty really doesn't want to be here, or they are just overwhelmed and are letting their overwhelmed state ooze out into the audience when they're teaching. And that's bad. We're human, I get it, but it's bad.
We've got another hand up, Dr. Wisinger, and let's have her go ahead and unmute, and she can ask a question.
Hi, this is Dr. Domfe, one of the hospitalists. So
Sure.
my question is, during the survey, did they actually ask the residents about what they perceive as teaching from us? Like how do we, because without knowing what they perceive, how do we tailor the teaching specifically to what they're supposed to know? Right. For example, if I talk about a certain topic, but they don't perceive that as teaching, then they don't realize that that's actually teaching. But let's say they have a specific, let's say they want us to kind of do a 5-minute, one topic a day, pick one topic about a patient, and they perceive that as teaching, then we can actually tailor our teaching to that particular thing, right? So it's kind of hard to determine what is being perceived as teaching from their perspective when we don't, I don't think I've actually heard anybody talk about what they perceive as teaching.
So that's a good point. I said early on that, residents, as was pointed out in one of the slides, that they often see if not a sit down, a dedicated moments of time on a topic as in a didactic format as, quote, teaching. That's actually fairly common. Faculty kind of see that as teaching, and the residency. We're going to talk about, community-acquired pneumonia with a patient we have admitted with pneumonia. That's fine. Excuse me, and that is a component of teaching. However, it is incumbent upon the faculty to also remind them that as we talk about how we're going to manage this patient in terms of ensuring greater success of adherence to therapies, for example, I tell them sometimes, I have to tell them, so look, we're going to learn a little bit about the role of social determinants of health, and what does that mean today at the bedside for the next few minutes. And I tell them that because you're right. Sometimes they don't understand that the definition of teaching is beyond just that concrete moment with a topic. But faculty also fall into that same trap because they don't realize that They're teaching constantly when they're with the residents. They're teaching professionalism, they're teaching science, they're teaching, interprofessional relations. All those are teaching pieces. And yes, sometimes you have to articulate it as such, but most of the residents do grab that. I would say, and I'll have Shannon or Jaya pipe in, who've obviously reviewed the survey more intensely perhaps than I did, is that a lot of the comments had to do with, time, respect, and time meaning how much time is spent and on rounding it and not always adhering or listening to their needs in terms of how much time they have to do other things. The respect factor was very big. The humiliation factor was big. Just the humanism component of that, the professionalism was big, more so even than topics, as it were. Shannon or Jaya, if you're on the line, you want to comment?
Sorry.
Hello.
Wasn't expecting to get back on camera. Sorry. No, I'm trying to think. That's probably the biggest thing, is kind of a combination of I think the residents' perspective is wanting a time set aside for lecture, just like was talked about. What we've always mentioned is just bring up, we're going to talk, we're going to teach. And it doesn't necessarily even have to be you teaching, right? Participate in teaching. Maybe assign your medical students to give a talk. We've got clinical pharmacists, and I've got a pharmacy resident who's just rounding with me. She did a talk. So that we do have time for teaching. It does mean your 2 hours of rounding now has to really be condensed, because you're going to need to give that 15 to 20 minutes. But that for the survey was most definitely part of it. I think part of what's also from the resident side is seeing faculty at already designated teaching sessions. So be that noon report, academic half day, whatever, is showing that the faculty are involved in that as well. So making sure that, if we're the assigned faculty to give a talk, we actually show up and are prepared and give it. But also, even if it's not us, that we're there, right? That they see that we do want to be involved and we're here and willing to kind of help them out. This is just the first one. A lot of the other perspectives that you guys are going to see over the rest of the series, is looking at research and scholarly activity and all of those, other things that the residents see. Teaching was the easy one to kind of start off with first for us, but there's a lot that the residents see, and that's on us, of really being involved and wanting to teach. So
I want to stress one point though, and again, all of us, both faculty and as a measure of that, the residents, I think too, will believe that if we as faculty believe that teaching is a topic-based event, we're not getting anywhere. We are not getting anywhere with regards to getting the residents to engage in learning those things that are important to managing patients. Knowledge about disease states unquestionably is important. Don't get me wrong. Do not get me wrong on that. But how to take care of patients, what to think about when taking care of patients is unbelievably important. And we as faculty need to stress that this is also learning. This is learning. It's okay to literally say that. So what did we learn today about, medication adherence or literacy assessment, or the importance of asking the nurses what's going on, or the importance of talking to the patient? What did we learn about, making decisions on antimicrobials or antihypertensives, or when to engage specialty consult? All that is learning. Every element of that is learning. And you need to sometimes say, what did we learn today, children? This is what we learned. And by the way, do away with the word children. But you know what I'm kind of getting at. If we stick with the fact that, rounds was rounds, but we had teaching for 5 minutes on pancreatitis today, we've blown it, in my opinion. We've absolutely blown it. So I'm saying that's my take, and I'm sticking with it very hard, because I think it's very, very important. And I think people are missing out on how much you have to offer with your experience to help residents learn how to take care of patients humanely, correctly, intellectually, etc. I don't know how else to put it.
And I feel like the piggybacking on what Shannon was mentioning, our next session for internal medicine faculty in October is going to be giving effective feedback. And I'm sure it's going to be one of the things that Dr. Raj is going to be talking about, is saying out loud, I am now giving you feedback.
Yeah,
And
literally.
learners appreciate that, so that they can differentiate a little bit between things that they need to be held accountable for and some things that, because there's a lot of new information that they're getting. So they like it when you say, I'm now giving you feedback.
I know it sounds crazy, but it's true. But I will say, given some of the comments out there, that faculty also still have a mindset of teaching is when I'm talking about subject X. And it's a bigger thing than that. And so sometimes you just have to say that. And sometimes the light bulb goes off. They're like, oh yeah, I did learn how to take care of Mrs. Smith, different than just the medical management of disease state X. So whatever.
Well, we appreciate your time. I don't see any other questions. Anything else you'd like to say, David?
No, I've said more than I probably needed to say, and trying to stick to my rule of listen with the intent to hear, not just to say, right? Some people listen with the intent to kind of speak back, but you really sometimes need to listen with the intent of learning and thinking. Anyway, that's that.